Assalamu alaikum. Good evening, everyone. I'm Dr. Mohammad Sadilyas, and I'm an assistant professor with the Orthopedics and Spine Surgery Department at Ghurki Trust Teaching Hospital, Lahore. And today, I'll be telling you about a device that we have devised for arthrodiastasis of hip. Let me tell you, I'm basically not a pediatric orthopedic surgeon. Though जब डॉक्टर सईद और डॉक्टर चिराग 7-8 साल पहले केस कर रहे होते थे तो I used to assist them and I assisted them for about 2 years. But primarily I do Ilizarov and foot and ankle. And since we are a multidisciplinary center, so my pediatric team wanted a device for hip distraction, so I came up with it. As we all know that arthrodiastasis usually describes articulated distraction to treat various conditions like avascular necrosis, chondrolysis or arthritis. And there are many indications in which there is a potential use of this device. And I'm not here to tell you about how effective this device is. This is already understood that arthrodiastasis works, and there is plenty of literature that you can find over the internet in which the efficacy of arthrodiastasis is well established. So are there any are all of you fellows, or are there any residents here as well? Any resident? Can anyone please, this is an x-ray of an 8-year-old boy. Can anyone please explain what's going on with the right hip? This boy has a history of on and off discharge. He's unable to bear weight. He has pain in the right hip. So can anyone explain what's going on? So the hip is destroyed, proximally and laterally migrated, right? And this is the frog lateral view. So we have a 8 or 9-year-old boy with 4 months history of on and off discharge, pain, and he is unable to bear weight. What treatment options come to mind? Anyone, please? Anyone? So you can tell me, please. Okay. How would you like to investigate? Okay. Okay.
Then we have to take, if we need biopsy,
Okay.
then we can take biopsy.
Okay.
And then we will start the definite treatment, we will start definite treatment. So it is going to sublux, it is going to sublux. So if first we will do the debridement, and if it is tuberculous, we can first reduce and first wire. Hello,
K-wire from where? From
your just truck to the middle. So
okay.
but it will then going, it will escape, it will escape this.
Okay. Okay. So any other options? Would anyone think of just doing a girdle stone while doing debridement, or would someone try to salvage the hip? आप डॉक्टर से थोड़ा elaborate करें.
ये active septic arthritis hip है जो
Tubercular. If it's tuberculous, then what?
अगर tuberculous है तो first I would took biopsy, confirm it and start ATT. लेकिन sometimes tuberculous को जब आप खोलते हैं तो बहुत ज़्यादा होता है. Most of the time end up with girdle stone.
Ilizarov hip reconstruction वगैरह तो नहीं इस एज पे करेंगे ये?
Second stage later on.
I would like to try to save the head as much as possible. I wouldn't go for girdle stone unless I think that it is not completely painful and it is not going to. I can't relieve the pain of the patient without any other means except girdle stone.
Okay.
So for 8 or 9 or 10 years, I would like to wait. because there is a lot of remodeling potential.
Okay, so you would open up the joint,
I will
clean
open
it.
up the joint, I will clean it, take the culture, and I will try to reduce it.
Okay, with
Start the better treatment.
Okay,
Yes,
okay.
If it can be reduced with the manually, then I will fix it with the clay wire.
okay,
Or if not, then we will.
okay. So no one. My topic is arthrodiastasis. So obviously, I'm here to show you a case on arthrodiastasis. But there are many devices that are known. I think most of you have seen these devices at least on internet. There is an Orthofix AO device which is most commonly used. Some people have tried Ilizarov technique for distraction. We also used AO device for arthrodiastasis, but that was, I think, Doctor said 8 years ago when we used to do this. So we got some AO Orthofix devices through donation. We used these, but afterwards we had them copied. But there were problems which we encountered. The first of one was that we were not able to achieve adequate distraction acutely using that device. And the other problem that we encountered in almost all of these patients, that during the treatment, the abduction and the reduction in distraction was lost in almost all of the cases. And that device, we had to keep the patient on partial or non-weight bearing. And the original Orthofix was not available, or it's very expensive. So 8 years ago, we abandoned the technique. So this is my you can say portfolio. I have 4 devices right now that are under my name. Actually, it's AAMS ARMS, Amir Aziz, the name of my mentor and my role model, and Muhammad Saad. I have 4 devices which are under my name. One is a limb lengthening plate. One is a halopelvic device that I think some spine surgeons might have seen. There is a there is a rail fixator for limb lengthening and trauma fixation, and this hip distraction device. How the concept came into being, some of the spine surgeons who are sitting here, one of them I know, they might have seen this halopelvic Ilizarov distraction device that I devised about 2 years ago for correction of severe spine patients. The pelvic construct was used in this device because it was so stable that it was used to correct severe degrees of scoliotic deformities, and the construct was stable enough to give very decent distraction force. So similar assembly was used to distract the hip. So this is the pelvic component of the halopelvic system which we used. This is the assembly which I'll be doing a live surgery tomorrow as well. We'll discuss this in detail tomorrow as well. There is a Ilizarov femoral arch. On the top, which is anchored to the pelvis with the help of 2 or 3 Ilizarov half pins. One is in the supraacetabular area, it is passed anteriorly. One is in the ilium, and another one is again in the supraacetabular area, and it's passed laterally. The main concept is we pass these pins in 3 different planes, so they give a multi-directional fixation and a very stable construct. And the other femoral arch is connected to the femur with the help of 3 half pins. I use this long sleeve. I'll show you tomorrow as well while passing the half pins. This is how the two components are connected. We have to pass the femoral pins while flexing the knee so that we don't engage the quadriceps. The both femoral arches are almost parallel. They are fixed in such a way that they are almost parallel to each other. This is the femoral component. Then this is where I get all the distraction and the abduction. There are two hinges which are connected slightly proximal and lateral to the axis of the hip. The both the anterior and the posterior. ये इसकी लाइट नहीं वर्क करती. ये sorry. This is one hinge, and there will be another hinge which is exactly below this one in the same line. This point is slightly proximal and lateral to the hip. So when I apply, as you can see, the motor is now applied over here, and when compressive forces are given at the motor, they give distraction and abduction at the hip joint. So by compressing the motor, we are able to distract and abduct the hip joint. So I'm going to show you a few cases so you will get a better idea. Coming to the first case, this was a 8-9-year-old boy with tuberculous hip. The biopsy confirmed it. So in this case, we decided that we're not just gonna do a girdle stone. Initial plan was to do a girdle stone, but we decided that let's distract it, give it some time to heal, and since he's a child, maybe the head will remodel. So this assembly was applied. As you can see, very adequate distraction force we were able to give, as well as abduction. Shenton lines were restored, and this was the gap. The child was, and the good point about this assembly is, since it's a very sturdy construct, the boy can walk. All these patients are allowed full weight bearing the next day, and the assembly was kept for about 4.5 months. And as you can see, during the phase, the head started to show, and in about 4.5 months, head appeared. And the ATT was continued for 9 months, and now almost 1 year has passed after the removal of assembly. The boy has some limb length discrepancy and an abductor lurch as well, which will hopefully improve, but he's painless, able to walk around. Obviously, we are this assembly is very new. We don't have long-term follow-ups, but I'm going to show you a few more cases in which you can see that very stable and adequate abduction and distraction can be given using this assembly. You can see another about 13-year-old boy with again arthritic hip. We were able to give this was again a case of tuberculosis of the hip. Very adequate distraction was also we were able to give, and healing in the head has already started. He's 4 months into the treatment. Now we plan to remove the assembly. Another case, in this case, she had sphere flexion and abduction contracture, and there was some sclerotic bone over here, where again we did Campbell's procedure, did extensive soft tissue release, took a biopsy here, and we were able to partly correct the contracture. So at this point, we applied this device. The plan was to gradually stretch out the soft tissues and correct the flexion contracture in her as well. So in this case, obviously the assembly was a bit modified. These are two motors. We just gave distraction from here, and we were able to straighten the leg. Now we have removed the assembly, and still we'll see how the response remains. This is another boy, slightly older, with again sequelae of septic arthritis. Again, we wanted to give him a chance before doing girdle stone or doing anything else. So again, very good distraction force we were able to give. In a lot of these patients, acutely, no matter how much force you apply, you're not able to give any distraction. So in all these patients, we give gradual distraction for about 10 days, 1 millimeter a day, twice a day for 10 days. And in 10 days, we are able to get very decent distraction. This is the assembly. All the patients are able to walk fully weight bearing the next day. Again, a 14-year-old boy. 4 months have passed. Now we plan to remove the assembly. Let's see how things work. But in 4 months, he's fully weight bearing, he's walking, and the distraction has not lost. This is a boy with Perthes disease. Again, we decided that we're going to try this. Again, we're going to try to contain the hip using this, and we're going to keep this assembly for about 5 months, and let's see how the results come. These are all static hinges, but this assembly can also be used to give a mobile hinge as well. So flexion extension is always also possible. Like in this patient, this is a pseudo achondroplasic patient who unfortunately developed this inflammatory arthritis as well. So in this patient, we see he's a very small fellow. We wanted to give an attempt in salvaging the hip. So we started him on DMARDs and applied this distraction. And in this patient, we applied a mobile hinge as well. So in this patient, this assembly, this and this maintains the abduction, and here we are able to give the hinge, so we can give flexion and an extension to the patient while he moves around as well. So obviously these are very early cases. I'm not here to advocate the efficacy and use of arthrodiastasis. It is already proven. I'm here to give you a device which can give stable fixation and good distraction and abduction force. Thank you very much.